So on our panel of experts, we have Dr. Filip Janku, we have Professor Julien Haroche, Dr. Eli Diamond, Dr. Mark Heaney, and perhaps that is everybody for the moment. Dr. Augusto Vaglio? Yeah. And do we have Dr. Karine Coutillo with us? Yeah, Dr. Lorenzo Dagna. And Dr. Stéphane Barete, if you'd like to take a seat also. Great, so as I said, you can stand to ask your question or you can raise your hand and we will have a volunteer come and bring the microphone to you. Okay, so I'll hand over to our moderator, Dr. Ronald S, and we can get started. Is that okay? Yeah.
Thank you. I suppose I'm not going to interpret German, French, and so forth. Yeah, okay. So feel free to raise your hands if you have specific questions. I also get questions from Facebook. Maybe I'll start with one question from the Facebook. The first question that I got is, what is the difference between Ecd and Lch? Anyone from the panel? Mark? Yeah.
So Langerhans cell histiocytosis, or LCH, and Erdheim-Chester disease, or ECD, are diseases that are in the same cancer family. They're both characterized as malignancies of the histiocyte, which are a type of white blood cell in the immune system. They have different characteristics under the microscope, and Dr. Dagna went over some of those earlier today. And so they share a number of characteristics in that they have some overlap in symptoms. LCH is a disease that's most commonly seen in children, although it can occur in adults. Erdheim-Chester disease occurs more often in adults. As I'll mention later today, they both have often mutation in BRAF, and we think that sometimes they're linked, and sometimes we can see the same, see both Langerhans cell histiocytosis and Erdheim-Chester disease in the same patient.
Thank you, Mark. Any questions from the audience?
Okay, hello. So the first speech that was made, you were speaking about all the possible treatments, and I remember you mentioned something called anakinra, and you were speaking of this risk of infections, and I didn't have time to write down where. I think it was like in the upper something. And I was wondering, how do these infections actually manifest? If it's something that it can be spotted, or if it shows somehow what are the symptoms when taking this type of medication. Thank you.
Lorenzo. Yeah.
Sure. Whenever you try to use a drug, whenever you try to use a drug that affects the immune system, you have the theoretical risk, at least, of reducing the activity of the immune system itself. So theoretically, you have an increased risk of infection. When we speak about anakinra, the risk of infection with this drug is minimal. I say minimal just because zero does not exist in medicine. What we are as close to zero as possible. I give you an information. This drug has been tested as an adjunctive treatment for sepsis. Sepsis is a condition in which the bloodstream is invaded by bacteria, and they try to use this drug to ameliorate the prognosis of those patients. At the end of the trial, there was no signal, statistically significant signal of an amelioration, but there was no signal of concern. So even in patients that have bacteria in their blood, the drug is not affecting significantly the immune response. So among all the drugs, all the immune suppressant, anakinra has substantially a minimal effect to infections, with regard to infection, yeah.
Thank you, Lorenzo. Thank you. Thank you. Can you hear me?
Good, so you can start to go. Hello, distinguished panelists. Thank you very much for your presentations. And I'm Joel Hayashida, San Francisco, California, patient here with my wife and life partner, Susan. So I think this question is on behalf of BRAF positive patients, and I'll ask Dr. Janku to address it. Last night, as we were walking back, I told you that I was part of NIH's phase 2 clinical trial for a dual regimen of dabrafenib and trametinib, and that very late after the trial closed in 2017, last year I developed a sensitivity to trametinib, brand name is Mekinist, and as a result of consultation with my doctors and with the NIH staff, I was taken off of trametinib. And so my question is, I guess trametinib is a cytokine inhibitor, but I think you believe that that one is necessary to be paired with the BRAF inhibitor. Is that correct?
It's not necessary, but there are advantages to that because kind of against the conventional wisdom, using actually two drugs is actually perhaps more powerful, but more importantly, in most instances with fewer side effects than actually using the BRAF inhibitor by itself. So dabrafenib, which is the BRAF inhibitor, which reverses the activation of the BRAF gene in Erdheim-Chester disease, by itself it can be active, but it can have some side effects such as propensity to skin lesions or even to skin cancer, which is called squamous skin cancer. The risk might be somewhere between 10 to 20%. If you actually combined dabrafenib with trametinib, you actually reduce that risk to down to 1%. That would be one of the examples. Another example is trametinib by itself, which is the MEK inhibitor, actually can cause quite often a skin rash, which can be relatively nasty. And that side effect seems to be much less prevalent when actually combined with dabrafenib. So what is actually quite unique for this combination is that these drugs together actually have fewer side effects. On the other hand, trametinib has some additional liabilities which dabrafenib by itself doesn't have. Trametinib may actually have, fortunately very seldom, but can have negative impact on the heart function, which may be the result for treatment modifications or discontinuation. It can sometimes actually affect the liver function. It can actually affect muscles, and that's what I believe some patients experience, which may actually require either dose reductions or interruptions. One of the paradigms which I think might be, and I don't think I think the jury is still out there, but one of the paradigm which we might consider in the ECD patients is instead of actually starting with the full doses which we use for cancer, actually starting with the doses which are lower and then actually go up if needed. Because the lower doses might have problems as well, as Dr. Diamond pointed out, for the brain ECD. The low doses might not be enough to control that, but I think it might be actually a better approach to go from the lower doses and go up if necessary, which might actually prevent some of the side effects which you perhaps experienced.
Thank you, Dr. Janku. And if I could ask all the panelists and you, if you would be willing to entertain email correspondence with my doctor. His name is Lloyd Damon at University of California, San Francisco.
So my email is in the booklet for this conference. So I mean, speaking for myself, I'll be very happy if you can get me connected, and I'm probably sure that most of the panel feels the same way about it.
Thank you.
Hi there. I'm Michael Waters, and this is Edith Waters from Toronto, Canada. First of all, thank you all very much for all the great work that you do. We do really appreciate it. The question I have, on clinical trials, one of the challenges we have in Canada for Edith is that we don't have access to clinical trials there for ECD. And you had mentioned, Dr. Janku, about some of the geographic barriers. With everything available with technology today and working with within an ECD center, how soon do you think there would potentially be access to those not living in New York or those not living in Houston? And what do you see as the timeline for that?
I think you just nailed that. I mean, exactly. I mean, with all the technologies which we have, we still keep doing the things same way as we were doing them pretty much in the 80s, which is I think it actually needs to change. The problem is that it's not only up to us, but it actually involves also the discussions with the regulatory authorities, because these studies are ultimately planned with the goal to lead to the approval. So I think that's actually a conversation which we really need to focus our energy on to make sure that someone's chances of or access to medicine is not determined by a zip code. I think it's terribly unfair. If it's up to me, this would go away tomorrow, but that's
Good afternoon, everyone, and doctors and professors. My name is Susan Liu. I'm the long-suffering wife of Joel Hayashida here from San Francisco. And I just have a follow-up question regarding Joel's dabrafenib and trametinib treatment that he underwent with the NIH clinical trial. Last year, Joel did suffer extreme pain, and he couldn't even move from several feet from the hallway to the living room. And so his treating hematologist, Dr. Lloyd Damon, was on leave. And so John Engstrom, the neurologist at UCSF, did a test for him, and his creatinine kinase level was 1,500, and the normal range is 500. I'm sorry, 15,000, and the normal range is 500 instead of 15,000. And so my question is that while we thank Dr. Janku for the suggestion that perhaps lowering the dosage of the trametinib from 1.5 milligrams to 0.5 or maybe even 1 milligram might be advisable to have with the dabrafenib. Joel's Erdheim-Chester disease has his involvement with his kidneys, and we are very concerned that his kidneys may go into renal failure, or possibly his rhabdomyolysis, that was the problem with the trametinib dosage, would cause him more problems going on that. So would you, as a panel, recommend that Joel go on vemurafenib instead? Because last year, and actually the year before, we had really difficult problems with requesting compassionate care chemotherapy medication from Novartis. I mean, we're very grateful that they finally approved it, but last year we had to submit 5 separate requests, and Dr. Damon had to submit 3 separate requests because they kept saying that it was incomplete or that they couldn't find our submissions, and we just barely got all the application completed by the December 31st deadline. And we're thinking of going with Genentech, which is more patient-friendly. But would it be advisable for Joel to stop the dabrafenib and or trametinib and just go on vemurafenib instead? Please, if you have any suggestions or recommendations, we'd appreciate it.
I can just give a quick suggestion.
Yeah, Eli.
Without giving very specific suggestions, all I would say that in regards to the particular problem of this rhabdomyolysis, this muscle damage type thing, I don't think that in all cases that has to mandate permanent discontinuation of the medicine. I've seen that many times, and strategies such as taking the medication on and off can help with that. And there's no one way to do it, but I think the things that you're mentioning are a good example of having someone manage your care who has experience with different types of dosing strategies, because I think there are ways to navigate things like this within the treatment you have rather than start from scratch. So that's my general answer.
Okay,
And
Filip.
especially since we know that you are in risk of that, again, I don't think this is like the best forum to give a specific advice, but just kind of very generically, this is type of complication which, if you know that it might happen, you can actually monitor the blood test for that happening and potentially, which can potentially be prevented to get to the same level as it got at the time when the drug was put on hold. So as actually Dr. Diamond said, I don't think that's necessarily a reason for giving up on the drug completely.
Augusto, do you have any renal
You were probably concerned about the renal complications of this muscle problem. Actually, the kidney insufficiency secondary to rhabdomyolysis only develops when you have a massive rhabdomyolysis. That means you have an increase in CK, CPK, which is huge. Minimal or moderate increases in CPK levels are usually not associated with kidney damage. So if you have renal insufficiency, this may be the result of other problems, more commonly obstructions of the kidneys or renal arteries, stenosis, or so complications that may be related to the disease but not related to treatment itself.
Okay. Thank you. Got two questions there. Okay.
Buongiorno, io arrivo dalla provincia di Udine in Friuli, sono sotto cura qui dal San Raffaele e volevo chiedere una cosa. Io, a parte tutti i problemi che ho, una cosa che mi dà molto fastidio è la sonnolenza che mi viene quando mi fermo. Se io sto in movimento non ho problemi, se mi fermo anche sulla sedia tante volte rischio di addormentarmi. È una cosa che può diminuire, mi resta, come può succedere? Che risposta potete darmi? Grazie.
Eli?
Sleepiness or fatigue is just extraordinarily common, and it's common both within the disease, untreated and when treated. And I think it can be caused by the condition itself and is a very common side effect of the treatments. So it's very difficult to navigate. Sometimes, I don't know the particulars of your case or what you're taking, but sometimes when it's very difficult to sort out, if people can manage it, I will do like a treatment holiday for a couple weeks, and you may feel tremendously better. And then maybe your dose could be changed. And so sometimes, just changing one aspect at a time and being patient, you can try and see what's the factor that is contributing most to the fatigue and sort of trying to be systematic like that. Sometimes that gets you nowhere. And I'm a strong supporter of giving medications to help with fatigue. Those are very well-traveled in various cancers. And there are a few different kinds of medicines that can give you a bit of a boost for your energy. Someone has to be cautious that you don't have a medication interaction or that you don't have certain kinds of problems like heart problems that would make those medications dangerous. But I would say that very small improvements in fatigue can give you a very big improvement in quality of life. And so it's something that can often be addressed. But sometimes medications can help quite a bit.
Buongiorno. Ho una domanda sulla osteoporosi. Io assumo Vemurafenib da 5 anni e cortisone da 10 anni e quindi ho l'osteoporosi. Volevo chiedere, l'osteoporosi può essere causata anche dalla patologia, dall'Erdheim-Chester, oppure dipende dal cortisone e poi anche dalla vitamina D perché non posso espormi alla luce solare per via del Vemurafenib?
Anyone in the panel? Okay. Lorenzo?
Yep. I think that the most plausible cause for that is the combination of the two things that you've just discussed, indeed steroid usage and sun exposure, meaning the fact that if you are not able to be exposed to the sun, that could be reduced the activation of vitamin D. There are actually strategies. On one side, I would say that one of the things that should be done ideally is to reduce the steroid dose to the minimum possible level, because it's quite well known that apart from osteoporosis, they will be able to generate other side effects, metabolic effects, first of all. So the ideal should be to reduce to the minimum possible dose, the steroid dose. On the other hand, there are a number of drugs that could be added to your therapeutic regimen. The most simple one is vitamin D supplementation plus increasing the amount of calcium that you eat every day. And second, there are some specific drugs that could be counteracting the negative effect of corticosteroids on the bone. So ideally, the combination of the two should be there. Erdheim-Chester disease per se is not characterized by osteoporosis, so it's not a typical manifestation of the disease, and is more likely associated to the treatment.
One more
Okay,
question?
I ask my question in Italian language for better explain. Vorrei chiedere, per un paziente, in questo caso mio padre, che presenta un coinvolgimento del cervelletto con tutti i sintomi che poco fa ha elencato il dottor Diamond, compresa l'alterazione delle emozioni, come potrete notare, vorrei capire se esiste un'alternativa al farmaco come Betanib, perché in questo caso non ha avuto una buona tolleranza e ha avuto una forte allergia. Inoltre presenta un coinvolgimento renale abbastanza importante, quindi volevo capire se la ricerca si stava muovendo verso questa direzione. Ecco.
Yeah. So the question is, we have a patient here who has central nervous system involvement and also has some emotional lability and is not able to tolerate cobimetinib. Is there an alternative drug to use in this situation? Not able to tolerate cobimetinib.
She said yes.
Anyone in the panel?
It's kind of, it would be important to know what exactly were the problems with Kobe, but trametinib might be a little bit better tolerated. The target is the same. It's also a MEK inhibitor. It also actually has some CNS penetration, meaning that it can actually address the brain disease. So trametinib might be one of the alternatives.
Trametinib is an alternative. Any other comments from the panel?
Forse mi sono dimenticata di specificare che è negativo la mutazione BRAF.
Oh, okay.
Yeah, I can get back to that.
The patient is BRAF negative, yeah.
Yeah, I can get back because actually I'm following the patient I'm speaking about. I don't want to go into a personal discussion. This is clearly one of the problems that can be something that everyone in the room is facing because it's difficult. All the legislation, as the gentleman over there from Toronto pointed out before, different countries may have different difficulties for getting the drug. For example, in Italy, it was easy to get cobimetinib. It's almost impossible to get trametinib. We're working on the specific. The other one. Again, sorry for that. I try to say again, this is again underlining, unfortunately, the issues that are different in different countries. For example, in Italy, we have a strong legislation for using different drug combinations and having payback by the national health system for drugs that are used for rare condition, but we need some scientific published support for that. And since there are published work on cobimetinib, and this is very stage, we're waiting for the results for the trametinib trial, at this very stage it's impossible for us to prescribe trametinib. So we perfectly know the situation. We have at this time fixed a bridge solution for the problem, waiting for the possibility of getting the other drug and having it available for the treatment of the patient. This unfortunately again underlines difficulties that we as physicians have to face every day. We would love to give every drug to everyone, but unfortunately now there are a number of barriers that prevent us from making the best choice that we may be considering. And we are trying to do, working with patient association, with ourselves, discussing with pharmaceutical company to get kind of different option for that. But this is unfortunately part of our activity and of the problem that we have to face in our daily practice.
Okay. Thank you. I have a question from Facebook here. Would like to know if signs of infiltrations in the brain is a mini stroke. So I think what this individual is trying to say is if there are signs of infiltration in the brain in a patient with ECD, how would you know if this is stroke, mini strokes, or ECD? Eli? Do they look similar, mini strokes in the brain and ECD findings by imaging?
I could imagine instances in which they could look similar, but I would say more often not. And so, then you'd kind of want to dig into the medical history and find out whether the neurologic problems that someone had were sudden, which would be sort of like along the mini stroke type way of thinking, versus more gradual, which could not be strokes. So I think there's interpretation of the scans with interpretation of sort of the overall history. Also, ECD in the brain will tend to change over time, whereas a single mini stroke that happened would not change over time. So sometimes the clinical story or the time will clarify that.
Good morning. I'm here on behalf of my father. He is in Panama, Republic of Panama. And in my country, there's no treatment for this disease. He's the first case. And he's been only taking prednisone, 25 milligrams daily, and he already has the brain, the central nervous system, and the bones affected. So I don't know what can we do actually.
So the question is, in Panama, these new drugs are not available for patients with ECD, and in someone with multiple sites of involvement, including the nervous systems and the bones, what are the treatment options?
So
Go ahead, anyone?
I don't know, first of all, that's a terrible circumstance to be in, I'm sorry. I don't know who the treating physician is. Sometimes who ends up treating a case of ECD is the person who ends up stumbling upon the diagnosis, and especially where there's no ECD history, that may or may not be the correct person. And so one thing you could do would be to try to find a physician who is someone who gives ECD treatments, even if maybe for other diseases. So is familiar with the medications, even if they may use them for something else. And that may be basically a leukemia doctor, or, a blood cancer specialist, or sometimes a melanoma specialist. I would offer that if you could ask that physician to reach out to any of us on here and make some kind of contact, and maybe we can be of help in providing guidance within the boundaries of what medications are available. Because I would imagine that some of the treatments, they exist and they may be given for other diagnoses, but may not have been given for this, but perhaps they could.
Thank you. So I understand this topic of fatigue is quite popular, it's quite common because almost everyone is dealing with it to different degrees. And I'm wondering whether it's something that it can be tackled somehow with physical activity, if there is some type of physical activity that it's recommended, or from going to take a walk and trying to walk as much as possible to some kind of trainings, kinesis, I don't know. Or is it something that should just be accepted as it is, and one should just, because I'm speaking on behalf of my father who just got recently diagnosed, and we're still trying to understand whether it's something that of course, to a certain extent, it's something that we need to accept, that it's going to stay like this, is always going to be tired in a way. But I'm wondering how much actually some kind of physical exercise could improve, apart from also the energy boost medication that you were mentioning earlier.
So the question here is, for someone with ECD with a lot of fatigue, is any type of physical activity or exercise, is there some type of prescription that could help with this symptom?
I'll say, if anything, not restriction, the opposite. I should have mentioned this when I was talking about fatigue medications. This hasn't been studied in ECD in particular, but in cancers generally, the most effective intervention for fatigue is activity, not resting. So I would say that to the extent that anyone can, to push themselves to be active will actually help with energy more than resting. And I can't prove that in ECD specifically, but that's something that has been studied in cancer generally.
Go ahead.
I would like to add something, because fatigue is generally accepted as a symptom as a manifestation of the disease, but you also have to look for other common causes. The first I think is anemia, which can be something that contributes to fatigue, and sometimes is really easy to treat. If you have a vitamin or iron deficiency, you can supplement. If you have renal disease, which causes anemia, you can use erythropoietin, which increases the hemoglobin level, and therefore you generally feel better. And another point that is usually necessary to test is whether you have a concurrent thyroid insufficiency, which is quite common in the general population. It's a common cause of fatigue, and it's even more common in patients with this disease. There are, of course, a number of other causes, but I think that in addition to thinking of fatigue as a manifestation of the disease, you have to rule out other causes.
Going back to exercise, I'm finding quite beneficial to actually have patients working with physical therapy, because physical therapy not only helps you to find out what exercise actually might be good for you to keep you active, but also actually help you to determine what is safe and what kind of equipment you might need to move around.
Yeah. So stay active and look for other causes of fatigue that could be reversible. Yeah. One question over there.
Hi, I just wanted to ask Dr. Diamond, you talked before about when there's brain involvement, having higher doses of medication, and then if there's side effects, maybe having a holiday from it and going back on, what kind of period of time would you suggest is long enough without it then regressing to take a break from the medication?
Yeah, so there's no rule, but what I try to think about what the actual side effect is and whether it's something that resolves quickly or sort of takes more time. So in some cases, a week on, a week off may be better for the kind of time period of the side effect, or 2 weeks on, 2 weeks off may be better. So sometimes giving a break long enough to see how long it takes for something to get better will then help plan what the interrupted schedule is. And I usually find that you want to take a break to let the symptom normalize as much as possible rather than let it just become more mild. So it's very dependent, but that's kind of the way that I think about it.
I wanted to ask a question about inflammation. I understand that in the past it was treated as a disease of inflammation, and nowadays the focus is on the mutations. So my question is there actually an inflammation in this disease, and does it have a role if there is inflammation, does it play a role, and what kind of role does it play in this condition?
So the question is, now that we know that Erdheim-Chester disease is predominantly due to a mutation, what is the role of inflammation and treatment for inflammation in conjunction with the treatment for the mutations?
Okay. Inflammation is still an inherent part of the disease, and indeed the cells that are involved are inflammatory cells. A fraction of those cells, they do bear a mutation, but probably the effect that this mutation exerts on those cells are a little bit different from those we typically expect in neoplastic disorder. Namely, not to go technical, but when you have a tumor, in the traditional way we think of that, you have a duplication and increase in the number of those cells. In Erdheim-Chester disease, you have no signs of this kind of activity. So cells, they just gather there and accumulate, but they do not duplicate in the site. So it's discussed what is the meaning of that. Possibly there's a proliferative effect early, so maybe in the bone marrow, although it has not been clearly identified for the moment. What is clearly happening is that this mutation forces the cells to be more inflammatory. So if you act on inflammation, you may have some results, but you are not acting immediately on the reasons for which this inflammation is there. On the other sides, we may say that if you just block the mutation, you don't have many direct effect on the significant number of normal cells that are there. So for this reason, probably, and some studies are showing that the ideal could be, if you don't control with either treatment, to have a combined treatment blocking both inflammation and. As we have discussed in this panel, sometimes it's very difficult for us to get one single drug. It's even more complicated to get the two of them. So, but this is again the reasons for which it's extremely important that experienced physician at least advise on the treatment, if not possible to follow up directly the patient, and literally tailor the treatment upon the different patient, because that's the best way to get the best results.
Question? Yeah. May I ask a follow-up question to the panel then? So fatigue obviously is a common symptom of ECD and could be worse while on therapy. Could some of these worsening fatigue after starting the targeted agents be from inflammatory changes as a result of the therapy? And the other question is, do you usually see resolution of inflammation when they have a complete or partial response to the targeted agents? Do you uniformly see the lab markers like CRP going down with successful therapy? Or can they go up instead? Oh, Lorenzo, or were you raising your finger?
I think is again quite variable. There are some drugs, namely interferon, that per se cause fatigue, for example. So unfortunately enough, this is a known side effect of the treatment, and you can do something to prevent that, but it's in the pharmacological property of the drug to cause this fatigue. Some drug may cause fatigue, as discussed before, as a side effect of the drug. Some drug can control inflammation. Some other, for example, again, interferon will be probably associated with an increase in inflammatory indexes, even if the patient is responding, because the drug itself is generating inflammation. So it's not that easy to parallel with inflammatory indexes and fatigue itself, because also, again, fatigue could be part also of the disease manifestation per se, specifically if the brain involvement is there, or also fatigue could be generated, as discussed before, if the patient for the disease is bedridden or limited in his physical activity. So the reduction in physical activity itself can be a cause of fatigue. So it's quite multifactorial. We don't rely on inflammatory indexes to define response or not, because they are dependent on a huge number of different factors. And we definitely do prefer to define a response to rely on imaging or functional studies more than that.
Eli, you have a follow-up?
I'll just add a little bit. I think that I'll say on the targeted therapies, I think that disease-related inflammatory symptoms generally improve. I think of bone pain as one, and things like fevers and sweats, those improve quite nicely. But when the drugs can have inflammatory side effects, I think the overall sum of inflammation in the body may or may not be overall less. So it may be different, but swapped.
Thank you. There's a question there. Yeah.
I'm currently taking 1 week on and 2 weeks off of vemurafenib. And I noticed in your slide, Dr. Janku, you talked about using 2 drugs instead of vemurafenib as a possibility. I also heard you say that you didn't want to very quickly switch drugs. So I'm just wondering, is there certain criteria or something in terms of when you would try something else, or?
At this point, not really. So, I mean, if you are on something which is working, I wouldn't fix something which is not broken. So there are some assumptions that two drugs might have better tolerability profile.
Okay.
And perhaps if we kind of take the evidence from some other cancers, maybe slightly more effective.
Okay.
But at the moment, there is actually not any really hard evidence for Erdheim-Chester disease that one is better than the other. I think we need to complete the clinical trial which combines both, hopefully get it to the patients and actually give these options. But at the moment, there is not really evidence which would be, which would actually mandate switching patients from vemurafenib to anything else. At the end of the day, vemurafenib still has the most evidence and is approved medicine, at least in the United States.
And how long have you been doing your trial?
Excuse me?
How long have you been doing your trial?
So this is actually a trial which started at NIH, then ultimately the NIH stopped the trial and then actually reopened at MD Anderson, so it's actually for a number of years.
Okay.
And the trial started sometime after the vemurafenib baskets, I believe it was 2013.
Hi everybody, I'm Antonio Penillo and I'm from Sicily. And actually the problem is that in Sicily we have 200 days of sunny weather, and we want to know if it's possible to integrate the treatment with something that can help to reduce the sun exposition problem.
So the question is there anything we can do about reducing sun sensitivity problem, the rash that you get from vemurafenib therapy, especially in Sicily, wherein you have way more sunny days than most places.
Technical problems. As a dermatologist, I can answer you. Indeed, in Sicily, it's very sunny, of course, and but it's very, very important, as you can see this afternoon by my presentation about dermatology and ECD, that we have to prevent with an extreme precaution and avoid sun for different reasons, but the major one are cancers, are skin cancers and melanoma that could be very damaged for patients. So especially with vemurafenib, that reduce the threshold of UVA tolerance that participate to the implication of carcinogenesis of the skin. So especially with this drug, we have to have a strict behavior regarding sun. And for practical things, I can show you this afternoon with all different things we have. We'd like to, like a guideline, I mean, my recommendation, but it could be more diffuse for patients with ECD and with patients taking these drugs to avoid a problem with the skin. So you have cancers, but you have also photosensitivity that are very strong, they are quite rapid, within 1 month, and so it's very helpful to explain, to educate, to inform how to put sunscreen with a high SPF above 50 and regular application, even if you are in Sicily, with most of the way to do with the hat, with the long garments, and many prevention, and that's the point. And it's true, it has been said later on, that combination, and you will see it, because we know it from these drugs applied to metastatic melanoma, and we know that when we combine these drugs, many cutaneous side effects regress. The kind of natural, biochemical protection, but otherwise, it's even with the combo therapy, it's necessary to prevent from the sun. But I will show you this afternoon, if you stay here, a large data from this point.
Yeah. So in summary, cover up, use sunscreen, and stay until the afternoon to listen to his talk.
That's the point.
Or move to Rochester, Minnesota. We don't have as much sun. Any other question from the audience? Okay.
Oui, bonjour, j'habite en France et je suis toujours actif. Par contre, comme on a parlé de fatigue, je ne dors pas la nuit, je suis fatigué le jour. C'est assez perplexe. Mais je fais encore du jardinage, il me faut une journée pour faire ce que je faisais en une heure. Et je fais de la kiné 2 fois par semaine, je vais en piscine faire de la gymnastique et je suis suivi en kiné. Donc j'ai le dos, mon dos est toujours raide, j'ai des douleurs dans le dos, les jambes, c'est sans arrêt, c'est toujours sur une base de 7. Et j'ai des crises dans tout le dos. Mais malgré ça, donc je sors, mais on n'arrive pas à voir que je suis malade. On ne voit pas la maladie. Par contre, la fatigue, quand on arrive, il y a des moments où vraiment elle tombe, hein, cette fatigue. Je m'y mets, hein. On n'a pas le choix. Le problème est quand je fais à manger, mais c'est ma femme qui fait le ménage après. Non, comme j'ai gardé l'humour, mais derrière, pour comprendre la maladie, c'est un problème. Après, quand on demande aux organismes, il vous faut une place pour une place handicapée, puisqu'il arrive des moments où on ne peut plus marcher. On arrive, je marche malgré les douleurs pour ne plus sentir la douleur, et des moments où il dit maintenant je ne peux plus. Alors il faut avoir des moments où les organismes vous acceptent en tant qu'handicapé.
Well, that's hard for me to summarize, but it's about fatigue and what we can do about it. I believe this afternoon we have a session by Juvi Estrada, or not? Okay, no, okay. So any comments from the panel? I think this question is probably very similar to the earlier questions. What can we do about fatigue? Our individual here has been quite active in fighting the fatigue, and I think he's doing everything he can to fight the fatigue. Yeah.
The only comment. Oh, sorry.
Yeah, I was just going to say,
Mark?
it's a challenging problem, especially when you're trying to balance pain and fatigue, because some of the medicines that are most effective in addressing pain can cause more sleepiness. And for the individual patient, a lot of times it's a balance in finding what's most effective for that patient, recognizing that it's not going to be perfect. That said, one can be active in addressing both pain and fatigue, and there are medical treatments for both. And things like stimulants can be helpful for patients with fatigue, although one has to be careful about over-medicating. But there can be an active approach, and it usually requires good communication with your physicians, and then sometimes pain specialists can be useful in addressing some of those medical management issues.
You said one thing that I want to comment on, which is that you don't look sick, and I think that's just an interesting feature of rare diseases generally, which is that the way that people are typically viewed as ill may not apply in the context of a rare condition. So you look well, so how could you possibly be so tired, right? That is, it's our job to sort of, put in the literature the fact that fatigue is a very common symptom, and if that should be sort of scientific knowledge, so that someone can say with authority about you that even though you look well, you may be incapacitated by fatigue. So I think you're commenting on something that is a common problem in rare diseases, which is that what people typically think of as ill may not be the case.
Filip?
I think to all the measures which were already mentioned for fatigue, and again, not knowing really any specifics about this, your specific problem and treatment, but sometimes actually using or adding drugs to the mix which modify the inflammation can help by multiple-fold actions, including reducing the pain and perhaps reducing the need for painkillers, which sometimes can contribute to fatigue, but also by actually modifying the inflammation can also actually help with fatigue. Sometimes these things are not always well addressed by kinase inhibitors, such as vemurafenib or cobimetinib.
Thank you. Perhaps one more question before we break for lunch.
Okay, I'm here again. Now, if it's possible, and if you can respond to this question about the state of the art. If there are some empirical evidence about the reduction of equilibrium issues with the new combination of the drugs. Only this.
I didn't get the question. Can you ask that question again?
If there are some empirical evidence about the reduction of equilibrium issues with the new combination of drugs that you started to study.
Equilibrium, balance. the question could be if there are evidences suggesting that the drug combination would be better for controlling balancing symptoms.
So, as you ask the question, no, in the sense that everything about balance as opposed to scans is people's observation, not really evidence. I would say that as an informal observation, I think that there has been some more favorable experience with neurologic symptoms with combined than with one, but that's a loose observation, I would say.
Oh, one more? Okay.
Ja, hallo, ich bin der Michael Sachser aus Deutschland. Ich habe zwei seltene Krankheiten, einmal die Ecd und einmal die essentielle Thrombozytämie. Zurzeit werde ich mit Celboraf behandelt als Medikament und ASS 100. Mich würde mal interessieren, gibt es da eigentlich irgendwelche Zusammenhänge zwischen beiden Erkrankungen? Ja oder nein? Und was macht dieses Celboraf letztendlich mit meinem Körper? Also wie wirkt das auf mich? Kann man das vielleicht so in ein, zwei Worten mal sagen? Und vielleicht nur als drittes, diese ASS 100, dieser Blutverdünner, den ich bekomme, da habe ich mal gelesen, dass der auf Dauer nicht gut sein soll. Was habe ich da zu erwarten?
Could you please repeat the question? Sorry, I didn't pick up your earlier statements. Can you repeat the question? I'm sorry.
Ach so. Ich wiederhole nochmal. Also ich leide unter der essentiellen Thrombozytämie, was ja eine Erhöhung der Thrombozyten ist, und der Ecd. Da ist meine erste Frage, gibt es da irgendeinen Zusammenhang, weil ich bei der einen Erkrankung unter Fatigue leide, wie auch bei der Ecd? Fragezeichen. Ich werde mit Celboraf behandelt, sprich mit diesem Medikament Celboraf und ASS 100, was zur Blutverdünnung dient. Was macht das Celboraf mit meinem Körper? Und ist die langfristige Einnahme von ASS 100 bedenklich? Weil ich habe mal sowas gelesen.
So our patient here has thrombocytopenia and is also on Celboraf. And is there a link between the two? I guess one question I have to ask Michael is, did you have the low platelets? Thrombocytopenia is low platelets. Did you have low platelets before starting the drug or after starting the drug?
Davor.
Anyone from the panel? Which drug is probably better to use with low platelet situation?
Is the disease low platelets or high platelets?
Low platelets, thrombocytopenia.
Okay.
So, no, I mean, it's quite difficult to give a precise answer to your question because there are a number of different medical conditions that can lead to low platelets. And also there are several reports associating Erdheim-Chester disease with different problems in the bone marrow, so in general in the production of red blood cells, white blood cells, or platelet. The question the colleague was asking is, for example, there's a significant association in which you may find elevated platelets and Erdheim-Chester disease. But in this sense, it should be investigated, and it's quite difficult for us. I don't think if you agree with me, but it's quite difficult for us to give you an answer from scratch, like here, because it should be investigated why you have low platelets. That could be completely independent of Erdheim-Chester disease. there are some cases of potential associations between the two conditions, and if they are independent, it's quite thinkable that you actually give a treatment for one condition and a treatment for the other one. So it's really difficult to comment on that.
So the answer is it really depends on what's causing the low platelets. And I'll talk to you afterwards, but you have to translate for me. All right, so thank you for attending. Oh, two more? Okay.
No, I can, sorry.
Yes.
No,
Yeah, so, okay. So what happens with Selborap? You know, does Selborap cause low platelets, or will it make the platelets get lower?
I mean, what in general, this is, I think, a general comment that I could make upon a number of questions that have been placed up to now. Everyone on this side of the table, and I think everyone on the other side of the table, will be more than happy to get rid of all those drugs. When we start a treatment, we should accept a kind of compromise, because clearly enough we have an indication. We know that every drug probably will be able to lead some side effects. And one of the tasks of the good physician is to balance the benefit of a drug versus the side effects of the drug. So with regards to the specific question, going back again to the difficulty of understanding the 2 points, is that Zelboraf may give a number of problems. Low platelet is not one of the most common seen in this treatment, but clearly enough, I can assume that if this drug has been picked up for you, is that because the benefit that could be potentially associated to the usage of Zelboraf for Erdheim-Chester disease outweighs the potential risk associated to that. And this is one of the reasons in that we physicians taking care of this patient, and in general, physician taking care of whatever condition, should balance every day. You give a drug, you expect some benefit, you may expect some side effect. You have to understand at what extent the two things go together in order to give the best for the patient.
So thank you for attending this session.